Squamous odontogenic tumor. Now we are going to discuss about the squamous odontogenic tumor. First, what is the squamous? Squamous cell is the type of epithelial cell, and this is a benign tumor. So it is also known as benign epithelial odontogenic tumor. Okay. Now, some important points of this type of odontogenic tumor is it can be misdiagnosed with acanthomatous and desmoplastic variants of ameloblastoma. Okay. Another point is it is also may confused with the well differentiated squamous cell carcinoma. This also will discuss in later on. Now we are going to discuss about the origin. There are four origins of the squamous odontogenic tumor. This is one, rest of molasses; second, dental lamina; third, surface stratified squamous epithelium; fourth, rest of serous. We discuss these four origin one by one. What is rest of molasses? It is residual cells from Hartwig epithelial root sheath that did not completely disappear. We have already found in first year, so we will not discuss about it. Here you can see that epithelial red cell of molasses are present in the parental ligament site. So you can relate the what lesion caused by the red cell of molasses infection. Actually, it is the source of epithelial proliferation for lesions that are associated with alveolar process adjacent to the lateral root surface of the teeth. Now, we discussed about this point, epithelial proliferation. Okay, we know that what is the tumor. Tumor derived from odontogenic tissue is it a neoplasm formed due to excessive proliferation of the cells, and these cells are not under the control of the stimulus. That is, even after removal of stimulus, the cells will undergo proliferation. This neoplasm proliferation even after removal of stimulus. Okay, so it provides epithelial proliferation to the lesions. Next, this point. At this point, associated with the alveolar process. Yeah, process. What is the alveolar process? Alveolar process is a ridge. This is alveolar process. It is a ridge. Okay, which contains socket for the teeth. Okay, this is alveolar. Next point. Now, which alveolar process is associated? The alveolar process adjacent to the lateral root surface of the teeth. That means lateral surface of the teeth. That means this alveolar process. Outer surface alveolar process. Okay. Now next point. Dental lamina. Now dental lamina. We found in first year at 7th week primary epithelial band divides into dental lamina and vestibular lamina. Dental lamina helps in initiation of tooth development, and vestibular lamina forms the vestibule. And the dental lamina gives rise to the deciduous tooth. So dental lamina source for that develop in association with the crowns of unerupted or impacted teeth. Now, what's dental lamina? We found in first year what is a tooth bud, and tooth bud how relate to the dental lamina. Now, this is the figure that how dental lamina related to the tooth bud. Tooth bud is primordia of enamel organ, and enamel organ gives rise to enamel, and enamel is a crown. So we can relate that dental lamina, if dental lamina is affected, the lesions will on the crown of the impacted or unerupted teeth. Now we will discuss about the another two sources: surface stratified squamous epithelium and rest of serous. And these two are the source of extra osseous variants. What is extra osseous? Extra osseous is outside the bone. What is the rest cell of serous? We found in first year after initiation up to development dental lamina starts degeneration, but epithelial and the epithelial cells of the dental lamina replaced by the connective tissue, but degeneration is not completed. The remnants of the dental lamina persist as the epithelial part or islands within the jaw as well as the in the gingiva. These are referred to as the cell rest of the serous. And figure of rest of serous. See, our gingiva, it is already outside the bone. So, and surface stratified squamous epithelium. It is, what is this? It is the covering stratified squamous epithelium. It is covering. So these 2 point from this from these details we can say that these 2 points are the extra osseous variants lesion. Clinical features. What are the clinical features? The patient age is 11 to 67 years. That means the people who is between the 11 to 67 years, the disease is most commonly occurred in these years. Sex. In case of male, is probability of this lesion greater than the in the female. Location. Mandible more commonly occurred in the mandible. In case of maxilla, it is also occurred. The central lesion is incisor cuspid area. Cuspid means canine. That means incisor and canine area. In maxilla, the lesion occur. In case of the mandible, where will be the lesion? The lesion will be seen in bicuspid and molar area. What is bicuspid? Bicuspid means premolar area. That means premolar and molar area. So from this we can understand that in mandibular area the lesion will be seen in posterior region. Then from these details we can say that in maxilla anterior region, in mandible posterior region. Okay. Now lesion presenting manifestation. The lesion presenting manifestations are mobility of involved teeth, pain, tenderness of percussion, and abnormal sensation. That means lesion जहाँ पे होगा या जिस दांत में होगा वो दांत मोबाइल होगा, पेन होगा वहाँ पे, टीओपी पॉजिटिव होगा, टीओपी पॉजिटिव होगा और एबनॉर्मल सेंसेशन होगा. Peripheral variant of lesion. The peripheral variant of lesion will cause socialization of underlying bone. What is the socialization? Socialization is a shallow dish. This is saucer like depression. This like. Now we are going to discuss radiographic features. No radiographical features is sufficiently to suggest the diagnosis of this lesion. Okay, but sometimes it presents as a semicircular or roughly triangular radiolucence area with or without a sclerotic border. And this sclerotic border associated with the cervical portion of the tooth root. Now, what is sclerotic border? Sclerotic border is a opaque border which is thicker or less uniform. Now, histological features. Hist- Under histological feature, the squamous odontogenic tumor is composed of islands of mature squamous epithelium entirely, no peripheral palisaded or polarized columnar layer. These are the columnar cells which are not present in the periphery of the islands. Figure A and B are the islands of the squamous cells, and C and D are the periphery of the islands. Peripheral layer of islands is quite flattened or least cuboidal. The squamous cells, that is, islands of mature squamous cell. These squamous cells are uniform with prominent intercellular bridges. These cells, squamous cells, exhibit no pleomorphism, that means no other form, no nuclear hyperchromatism or mitotic activity. Mitotic, this is mitotic activity. Nuclear hyperchromatism, that means this is a dysplastic features. This is a dysplastic features, and this is abnormal cell within the tissue. That means there is a chances of keratinization with no enamel pearl. What is the enamel pearl? Enamel pearl is a hard lump of enamel. जो बूंदी की तरह दिख रहा है वो एनामेल पर्ल है. Small droplet structure. Three other variable findings are laminar classification in the epithelium. Laminar means palate. Next point, second number, microcyst formation involving only a small portion of epithelial islands. Third number, globular hyaline eosinophilic structure within the islands. This is not a amyloid. There are three other variable findings are laminar calcification, microcyst formation, and globular hyaline eosinophilic structure within the islands. These are not amyloid. These three are other variable findings. These three are other variable findings: laminar calcification. What is amyloid? Amyloid is a amorphous fibrillar protein. It is eosinophilic. It is associated with the amyloidosis. Earlier we discussed about the misdiagnosis, acanthomatous and desmoplastic variants of the ameloblastoma misdiagnosed as squamous odontogenic tumor. Both variants exhibit squamous differentiation with tumor island as in the squamous odontogenic tumor, but these two acanthomatous and desmoplastic variants also demonstrate ameloblastic changes of peripheral cells. The ameloblastic changes include columnar shape of cells, polarization of elongated nuclei away from the basement, and vehiculated or clear cytoplasm. But these changes not found in the squamous odontogenic tumor. That's how we can differentiate these two acanthomatous and desmoplastic variants from the squamous odontogenic tumor. Another case, squamous odontogenic tumor also may confused with the well differentiated squamous cell carcinoma. But how can we differentiate these two? Then in Squamous odontogenic tumor cells, no cytological malignancy, but this cytological malignancy seen in the squamous cell carcinoma. That's how we can differentiate squamous odontogenic tumor from the well differentiated squamous cell carcinoma. Now, treatment of the squamous odontogenic tumor. There are three processes of treatment: enucleation, curettage, and local excision. What are they? Enucleation is the surgical removal of all tissue, both hard and soft tissue, involved in the lesion. Curettage. A curettage, it is a simple type of electrosurgery in which a lesion is scraped off and heat is applied to the surface to seal the blood vessels and stop bleeding. Okay, here heat is applied to the surface to seal the blood vessel so that it stop the bleeding. What is local excision? It is the cutout of tumor and some normal tissue around it by using a scalpel. A scalpel is a sharp knife. Amount of normal tissue removed depends on how deep or how large the tumor being removed. That is a lesion and we cut like this. Okay, that is cut out the tumor. This is cut out tumor and some normal tissue. This normal tissue around by using a scalpel. Okay, amount of normal tissue removed. और कितना गहराई में है उसका ऊपर डिपेंड करके अमाउंट ऑफ नॉर्मल टिश्यू रिमूव